to things that are more complicated. So, if you're on a medication which reduces the risk reduces your chance of making normal bone, try to get off it if you can. So if you're on steroids, try to get the dose down to the minimum if possible. This isn't always possible, but certainly I really think that physicians use steroids much too casually. They have a little pain in your shoulder. Okay, let's give you a Medrol dose pack for a week. You don't really need to do that. Wouldn't a couple of aspirin or a couple of Tylenol get you through this? Maybe you don't need steroids for that. Certainly, stopping smoking is another obvious way to benefit your bones as well as the rest of your body. Fall prevention, so physical therapy, physical exercise, making yourself stronger. You cannot rebuild bone after the age of 30 with exercise. But you can delay loss of bone and you can make your muscles stronger so when you fall, you protect yourself and don't just go clunk on your hip and break something. So again, medications which make you confused or woozy or lightheaded, which make you more likely to fall. I saw a patient this morning who doesn't have osteoporosis, but she came in saying, every time I stand up, I get dizzy and I feel like I'm going to fall down. Well, this is not a good thing for an 80-something-year-old lady. You have to do something about that. Make sure your environment is correct. Throw rugs, right? Throw rugs that look cool, but you trip over them and then down you go. Or they slide across the tile floor. You have to be careful of your environment. And then obviously balance training for people who have poor balance. Physical activity we talked about, and we obviously need to do adequate calcium and vitamin D. This makes the news. This was one of those Diane Sawyer things that we got to see on TV. How much is the right amount of calcium and vitamin D? And so we can talk about that later on. But clearly, some is important, and more is not necessarily better. And obviously, testing your bone density to find out if you're at risk to see if we can change that. So this is all a list of things that you could possibly take for your osteoporosis, or for treatment, not for prevention. So alendronate has been around for a long time as Fosamax. It's now generic, and so if you get a prescription for a treatment, your insurance company is going to want you to be on alendronate because it's generic. We have zero data that alendronate actually works, because there's no study for generic. Fosamax had to prove that it reduced the risk of fracture. Alendronate does not. It simply has to prove that when you put it in a glass of water, when it's dissolved, it's alendronate. It doesn't have to prove that it gets into your body when you swallow it. We don't know about it. So generic is generic. Recidronate is Actonel. It's also now something called Altivia, I think that's right, which is the one you can take not on an empty stomach, same drug. Abandronate is Boniva. Zoledronic acid is Reclast. We'll talk more about Reclast in a minute. Estrogen, you can still take estrogen. People don't generally take estrogen anymore for osteoporosis, but it works. So that's, for people who are taking this, they may not need something else, at least in the short term. Raloxifene is Evista. This is a drug called the systemic estrogen receptor modifier. It's a very commonly used drug. It's not as potent as the other guys on this map here, but it is a useful drug for some patients. Calcitonin is a nasal spray. This is a drug that I never use anymore, but still out there someplace. The newest kid on the block is denosumab or Prolia. This is a twice-a-year injection. We'll talk more about that one later on. And the only therapy that works at this end, the one that actually builds bone, is Forteo, or teriparatide. All the rest of these agents work by slowing bone breakdown. Only Forteo works by actually increasing bone formation. So keep that in mind as we talk some more. So, who gets treated for osteoporosis? Patients over the age of 50 with a fracture that you know about. A bone density score that's worse than a number called minus 2.5. 2.5 is simply the number of standard deviations above the average person, age 30. It's not a magical number in any other way, but the way that bone densities are done is we do this little bone density test, which is basically a little bit of x-ray through your bones, and we compare it to a huge database of normal people and compare you to a 30-year-old, whatever age you might be. We compare you to your age-matched person as well, but that's really irrelevant. We don't care about that anymore. because the average 70-year-old woman has osteoporosis. That's the average. So if you're just average, you still have osteoporosis. Doesn't help to know that you're just average. Low bone mass is what used to be called osteopenia. So osteopenia is you're not normal, you don't have osteoporosis, you're in between. Most people with fractures have osteopenia, not osteoporosis, because there are way more people in this category than the ones in the osteoporotic category. The risk is higher here, but the actual number is higher here. I have a patient that I saw a week before last who is 75, who has a fracture of L1 vertebra, whose bone density is basically normal. But she has osteoporosis, she broke a bone without doing anything in particular. You cannot go only by bone density. You have to go by history as well. So this is a bone density. This is the data that you get. This happens to be somebody with a very, very low bone density. So this is how we do it. This is your spine, front to back. Okay, so we're looking at your spine this way. This is T12 down to L4. We scan L1, 2, 3, 4 as the bones that we look at. We don't look at bones above that or below that because they are too hard to reproduce on a bone density. And so we get a bone density score for all of these, but we do the average here at L1 to 4. And you can see this person, if you can read that from the back, is -4. They are really, really low. And if you look at this little table here, they got way worse over time. I can't remember who this patient is or exactly what the story is, but you can see they did not do well with either no therapy or whatever they were being treated with. They're down almost 9% in the 3 bone densities that I have done for this patient. This is the hip. We do both hips. We do our own DEXAs. In this institution, you can get DEXAs from 3 different people. From us, from Advanced Radiology, or from the GBMC osteoporosis group that's over in the West Pavilion. I would not tell you they're all equal in quality, but they're all pretty good. So we do both hips, and you can see this person is almost as bad in the hip as they are in the spine, -3.4. And this person also went down in the hip, but not as badly down here as they did in the spine. So this is a high-risk person. This is the data you get from a routine DEXA. And then if you get a bone density that's in between, you can then predict something else, and I'll show you that later. So this is another thing that you can do on a bone density. This is called vertebral fracture assessment. So on the same test, we can do a lateral spine. This is your whole spine, neck right down to L5 here, which we can get with the same machine, and we can assess for the presence of a fracture. Most vertebral fractures are not clinically recognized. You had a little back pain, went away in a few days, you didn't go to the doctor, you didn't pay any attention. You go to the doctor, you get measured a year later, you've lost ½ an inch in height. That's the way you know. And then you find this when you do an x-ray. This is a collapsed vertebra on the anterior side. So most of these are asymptomatic, or the patient can't remember anything specific about when this occurred. Some of them can be very severely painful, so it varies from patient to patient. In clinical trials, what you do is you measure the height of these vertebrae to look for fractures. And so most clinical trials that look at fracture prevention, excuse me, actually look at what are called morphometric fractures. They measure the height of the vertebra, not go by clinical events. Well, by clinical events, you have to do way more patients in the clinical trial to get your answer. If your bone density comes out in that osteopenia low bone mass range, you're not above -1 and you're not worse than -2.5, you're in the -1 to -2.5 range, and you're not on therapy, WHO, the World Health Organization, now recommends you do something called a FRAX score, which estimates your fracture risk. And it takes into account these items: age, sex, weight, height, previous fracture,